everyone, welcome to another fertility Q&A series. I'm so excited to have Dr. Meera Shah on with me today to answer your fertility questions. Once again, you guys sent me so many great questions. I have pages and pages of questions here, and we're going to try and get through all of them in the next 30 minutes or so. So I'm so excited to have Dr. Shah joining me today. And as soon as she comes and asks herself to join, hi Cherie. As soon as she sends a request to be live with me, I'll invite her right on. So I hope you guys are having a nice Sunday. I did an interview yesterday with Dr. Nicole Kangas, and she taught me something really important that I felt like I wanted everyone to hear. And that is that you don't have to feel unwell going through fertility treatment. So it's so important for you guys to find your team, find a therapist to talk with you through this process. Hi, Meera.
Hi, Amy.
It is
How are
so
you?
awesome to
Good
have you here
morning.
today. Thank you. Good morning. So, how's your morning going?
It's great. I'm glad to be back with you today.
Oh, thank you. So, why don't you just tell people who are joining us right now where you practice? Tell us about yourself so that they can get to know you a little bit better too.
Sure. Well, good morning or good afternoon, wherever you are. Thank you for joining us today. My name is Dr. Meera Shah. I am a double board certified OBGYN and reproductive endocrine and infertility specialist. I actually practice very close to Dr. Amy in the San Francisco Bay Area. My practice is Nova IVF, and we're based in Mountain View, California.
Perfect. Thank you for that. So, are you ready for some questions?
I'm ready.
Let's do it. Okay, so the first question here is, hi doctors, thanks for doing this morning. My first transfer was a success. I'm pregnant right now, but I'm cautious because I've had a miscarriage previously, which was due to a genetic issue with the pregnancy. My question is, what's my chance of pregnancy now? Chance of pregnancy now. My embryo was a 5AA. It was genetically normal based on PGS, PGT. My first HCG was 380, 11 days post 5-day transfer. So what would you say to that person who's asking this question?
Well, first of all, congratulations to you. That's very exciting. And the first thing I would say is generally with a good grade embryo that's been genetically tested, we generally quote a live birth rate of about 65 to 70%. So the odds are certainly in your favor that your pregnancy is going to be healthy. However, we do know that there are some limitations to genetic testing. There can be errors in the results. There can be mosaicism in the embryo. We know that there are other embryo factors other than genetics that are important. So I generally quote about a 10 to 15% miscarriage rate, even after genetic testing has been performed on the embryo. One other positive thing for you, though, is that your starting HCG level was really strong. It was 380. So that's a great first sign, and I would make sure that you follow up with your doctors for your first ultrasound, and I wish you all the best of luck.
Yeah, that's great. Okay, here's some more questions, and this is just from one person, and she sent us 5 different questions, so I'll go through them. If you're using birth control pills for IVF, what is the optimal antral follicle count?
This is a really great question. A lot of women are on birth control pills before they start a cycle, whether it's for egg freezing or for IVF. And the first thing I just want to talk about is what antral follicle count means. It is a marker that we use for ovarian reserve, and it's actually a great predictor of response to ovarian stimulation. And it's very much age dependent. So, the way that I explain it to patients is that when you're younger, you have more eggs stored in your ovaries, and your body sort of calibrates the number of eggs that it releases every month. So you have a higher antral follicle typically when you're younger, and it decreases as you age. When you're in your mid-20s or so, a normal antral follicle count might be about 15 to 20. As you get into your early to mid-30s, that might be a little bit lower. And then as you get into your 40s, it might be slightly less than 10, about 8 to 10 or so. So it really is an age-dependent process. And I will stress to you that quality is so much more important than quantity. And by quality, I really am referring to the genetics of your eggs, which are very much linked to your age. Now, birth control pills have been shown to potentially transiently suppress the ovarian reserve. We know that this is a reversible process, so that when you stop birth control pills, your ovaries bounce back pretty quickly. So that's very reassuring. But we do see that potentially for some of my patients, when I have a sort of feeling that their long-term birth control use, and that I define as over 6 months of use, has potentially suppressed their ovarian reserve, I will potentially have them come off of pills for a month or two before I stimulate them for a better response overall.
Yeah, and that's important for egg freezers too. And then how about the AMH and the effect of birth control pills on that level? What do you see?
So there's actually some great studies on this, and there was one study that showed that being on long-term birth control pills can, again, transiently suppress your AMH level as much as 30%.
Mm-hmm.
So again, if you've been on birth control pills for a long time and you have your AMH checked, I would recommend, if you're not satisfied with that number, you really want to get more information about predicting your response to stimulation medications, it might be worthwhile coming off of pills for a month or two and reassessing your AMH.
I agree. And what's the general timeline transitioning to frozen embryo transfers? What's the general timeline for a frozen embryo transfer?
So I would say this is largely clinic dependent, but on average, it can take anywhere from 1 to 2 months.
Mm-hmm.
And there are many different methods in which you can do a frozen embryo transfer. Many clinics utilize the natural cycle method, in which if you have normal ovulatory cycles, you can time an embryo transfer to when your body and your uterus is most receptive to accepting that embryo. Now, the advantages of that are it is more natural. There is no hormones typically to be taken in that type of cycle. And there's actually some emerging studies to show that there might be decreasing rates of preeclampsia and hypertensive disorders in pregnancy in natural cycles. And that might be related to some of the benefits of the corpus luteum in pregnancy in the first trimester, especially as it relates to placentation. The other method as the alternative to the natural cycle is a programmed cycle or medicated cycle. In these cycles, patients will take typically some form of estrogen followed by some form of progesterone. And some of the advantages of this type of preparation is that you have a little bit more predictability over when your embryo transfer is going to fall. For certain clinics, that helps with coordination with the thaw of your embryo. And in general, you have a little bit more time to build up your uterine lining if that's an issue for you. So there are pros and cons to both types of methods. And in general, it takes about 4 to 6 weeks. It might take a little bit longer depending on your particular situation.
Right. Everyone's body is different. And their next question is, how do you know when to do the transfer? What is the lining thickness and the appearance that you're trying to achieve?
So typically we will reassess the uterine lining after at least 7 to 10 days of estrogen exposure. At that time, what we're expecting to see is, number one, that the uterine thickness has reached at least 7 to 8 millimeters. That's usually very reassuring to us. The second thing that we like to see is the pattern of the uterine lining appear to have 3 distinct lines. We call it a trilaminar uterine lining. And that relates to the composition of the uterine lining in the estrogen phase of the cycle. So we look for those 2 things. There are other ways that we can assess the uterine lining, including uterine receptivity tests and other tests to look for endometriosis in the uterine lining. There was actually an interesting study that was published in one of our journals, Fertility and Sterility, I believe in the last year or so, which looked at the impact of the progesterone on the uterine lining. So they actually looked at the lining at the time of an embryo transfer, and they were looking at compaction, or how much the uterine lining changed in thickness. And they found that the more the compaction they saw, the higher the implantation rates. Now, this is not something that I think most clinics do, but it's an interesting finding and something worth investigating further.
Yeah, I wonder if we'll be bringing patients in the day before transfer more often to
Mm-hmm.
look at that. Okay. Do you recommend ICSI or natural IVF for a couple with no male infertility and has been pregnant before?
This is a great question. And my opinion on this is that ICSI is really overutilized in the United States. I think that if someone has a completely normal semen parameters, especially if they've had a prior pregnancy, that's evidence that the sperm works and that a natural conception can happen with using conventional insemination in the lab. So there was actually a really nice study to validate this argument, and it was published in a very large journal a couple of years ago.
Mhm.
And they compared IVF outcomes and fertilization rates amongst men who had normal semen parameters and abnormal semen parameters. And what they found is that for men who had completely normal semen parameters, the fertilization rates were actually higher when they did natural insemination compared to ICSI. So again, this goes back to if you actually understand the technique of ICSI, when the embryologists in the lab are performing ICSI, what they have to do is first strip off all of the support cells from the egg, and then they can perform the manipulation of the sperm into the egg. And some of those support cells might actually be important for developing further cellular competency in the embryo. And so for those eggs that might be on the fence of, egg maturity, having those support cells around it might actually help improve its chances of fertilization the next day. Mm-hmm. So in my opinion, I think that if sperm counts are normal, that conventional insemination or natural methods are actually superior than doing ICSI.
Yeah, I agree. And I think sometimes what happens is people make these decisions, and then at the time of the egg retrieval, the decisions aren't changed. So for example, what if the guy had a bad sperm day and you still did conventional, but it should have been ICSI? So it's important to have a doctor like us who will step in, take a look, and confirm that it should be conventional, or maybe we need to change the plan. So thank you for that. Yeah. So now we have another question. My wife is 43. I've had 3 IVF cycles from 3 different clinics. We're financially strapped and only have one more shot. Egg donation might be our only chance. How do you know which are the best clinics? And also, how do you know whether you should use frozen eggs or fresh eggs?
So first of all, egg donation is a very effective and very wonderful way to build a family. And it's an option that a lot of women and couples have, especially if the female partner is over the age of 40 and particularly over the age of 42. I've had just wonderful experiences with couples looking back on their experience, very positively. So, the first thing is that you can look for clinics that might have their own internal egg banks. There's a few of those across the country, and you can call the clinic or find that on their website. But I would say most clinics utilize a third-party agency to find an egg donor. And these are agencies that can help you find a match based on the factors that are important to you, whether it be certain physical characteristics, certain aspects of their background. And, the agencies actually have quite a bit of experience with this. So there's 2 general methods that you can use when you're looking for a egg donor. There are egg banks that actually contain frozen eggs, or you can go down the route of using a fresh egg donor. The advantages of using an egg bank is that generally, the cycle's already been completed for that donor. They will essentially sell anywhere from 6 to 8 eggs for a certain fixed cost. They can ship it overnight to a clinic, and the process can be very, very fast, depending on what your selection criteria is. So for couples who are really on a short timeline, who want to move forward more quickly and potentially want to have some cost savings, using a frozen egg bank might be the right option for you. Another important factor to consider is how many children do you want to have. If you're only getting 6 to 8 eggs, I think it's realistic to really potentially have a chance for 1 live birth, but probably not 2. Mm-hmm. So that's when you might want to consider a fresh egg donor, because oftentimes with a fresh egg donor, you can get easily 15 to 20 eggs or more. And if you're thinking about having more than 1 child, you can really prioritize having those siblings being genetically related. So, the other advantages of using a fresh donor are that the cycle is actually completed at the clinic. Mm-hmm. And so the embryologists typically feel more comfortable because they're handling the eggs, they're handling the fertilization. They can, do all the embryo culture under their own watch. So a lot of clinics actually do prefer to use fresh egg donors, but both options are excellent and worth considering depending on your particular situation.
Great, thank you for that. Here's another question. There's some studies that show a slight increased risk of congenital anomalies, developmental disorders, autism, maybe even cancer in children born after IVF with ICSI. I realize some of these studies might be confounded due to the mom or parents being older or having health issues that led to infertility, but I've also seen studies that have controlled for these factors and still found a correlation. Would you be able to speak to what counsel you give your patients when it comes to the increased risk from IVF ICSI?
Mm-hmm. So this is something that's actually really difficult to really study. And there have been a few studies out there, and there are some well-documented risks of ICSI, which include a slightly increased risk of birth defects. Now, it's important to know that in the general population, the risk of birth defects is about 3%. So when you think about the actual absolute risk increase, using IVF and ICSI, it's actually not that significant. It may be a matter of 1 to 2% more.
Mm-hmm.
Now, some of these studies have been limited by the fact that there has been underlying male factor contributing to the reasons why ICSI was used in those studies.
Mm-hmm.
And so when you actually isolate that variable out and you look at outcomes of IVF and ICSI cycles where there was not a male factor, there really isn't too much of an increase compared to the general population. So what we do know is with an underlying male factor, we know that certain chromosome abnormalities are associated with low sperm counts. So there are increases in sex chromosome and euploidy chromosome differences amongst the embryos that are tested. And that is something that is important that I counsel patients about. The last thing I sort of overall just reassure patients about, though, is that there have been some really well done studies that have looked at the outcomes of children, specifically their developmental progress and their neurodevelopmental milestones at 5 years. There's a very nice study that reassured us as providers, and now that we can provide that information to patients, that the outcomes were the same in both natural conceptions and conceptions that were conceived using IVF and ICSI.
Right. And then the same person asked the question, I'm not interested in knowing the gender of my embryos, but I'm just curious. I heard that most embryos through ICSI are male. Is that true?
So this is an interesting question, and one that I actually looked at both at my current clinic and when I was a fellow at Stanford. There actually potentially might be a slight ratio imbalance in favor of male embryos at the blastocyst stage or the day 5 stage. And there was a great study that actually compared cleavage stage embryos, which are day 3 embryos, compared to blastocysts. And they found about a 10% increase in offspring that were male when embryos were transferred at the blastocyst stage as compared to the cleavage stage. So there might be something there. There hasn't been a clear mechanism that has explained this. Some people are looking at X chromosome inactivation that's involved with female embryo development, but it's not clear. But there does appear to be a very, very slight ratio imbalance in favor of the male gender. Now, this might be lab specific, it might be related to other things, so there might be other confounders. It really hasn't been studied in a larger cohort where we can look at those confounders.
If you want a male, maybe go to Stanford. I'm just kidding. All right. So I recently went and did IVF. This is another question. My husband and I have been trying for 2 years. I just turned 40. My follicle count was 7 to 8, but only 2 follicles responded to the treatment. Can my egg quality be improved? Can anything be done to make my follicles respond more? Should I try IVF again? Those are basically the questions from this person.
So yes, these are challenging cases when you have both age and low ovarian reserve as challenges to have good outcomes with IVF. But I will say that I've had countless patients in your situation who have been successful if they've continued to try. So I do want to make sure that you feel hopeful that potentially a different set of eyes looking at your case might have a very different approach. Some of the things that, when I look at a chart like that, I might consider is, a different protocol stimulation. We know that sometimes being overly aggressive with women who have diminished reserve can actually result in poor outcomes with embryo development and IVF outcomes overall. So I might potentially choose a minimal stimulation protocol, which might potentially work better and even be a better experience for the patient because they're not on as many medications. The duration of the stimulation matters, the dose of gonadotropins, the stage at which you freeze embryos and transfer them. All of those things can be looked at and potentially changed and modified. And it certainly is valuable for us to have prior cycle information to help us change and modify things as we think about what we can do differently in a subsequent cycle. But, there are some limitations to that. I mean, biology is something that we, can't reverse and can't improve and can't fix to a certain extent. So sometimes even with a different protocol or a totally different approach, your cycle outcome is going to look, the same. But in terms of how you can improve your egg quality, I would say generally speaking, having a a very healthy lifestyle is important. We know that eating well and having a normal body mass index plays an important role with good egg quality and sperm quality. We know that there might be some benefits to certain supplements such as coenzyme Q10, DHEA. Some clinics will utilize the use of human growth hormone during IVF stimulations to improve egg quality. So there certainly are some things, and I would talk to your clinic and your doctor about what might be best for you.
Yeah, absolutely. Okay, here's another question. I'm 34 years old. My AMH is 0.3. I have a history of Sjogren and Hashimoto's. I've completed 4 IVFs, and I have 1 high mosaic embryo that's trisomy 15. Question is, should we transfer this embryo or do more IVF? What would you suggest?
These are really challenging cases to
I
counsel
know.
patients about mosaic
I
embryos.
know. I
We could have
know.
a whole nother session on
I
that.
know.
But you know, it is coming up more often in our conversations with patients because genetic testing companies are giving us that information. Now, just a couple of points about mosaic embryos. The first thing is that, you know, when we get genetic testing results from the company, we have to sort of take into consideration what the limitations of those testing results are. We know that mosaicism is part of normal biological process of embryo development, and there have been many studies to show that at the day 3 stage of development, embryos are more mosaic as compared to the day 5, day 6 stage of the blastocyst embryo. And that's just part of the normal self-corrective process that the embryo is undergoing as it continues to develop. We know that potentially the technology platform that you're using can have errors, and they can potentially report out mosaicism. And so there's a lot of potential explanations for those results. But that being said, I think the number one thing to do if you don't have a normal embryo and a mosaic embryo is the only embryo you have to potentially transfer, the first thing that our clinic does is have you meet with a genetic counselor, because we want you to really understand what the risks are of transferring that embryo. Is there any data to suggest that there could be significant abnormalities in that fetus and child? That's important information for you to make your decision. And that really depends on which chromosome is involved, how much of the chromosome. We're learning a little bit more about transferring segmental mosaic embryos, which is just a part of the embryo, which is missing or duplicated as compared to the entire chromosome. Those embryos might be preferable for transfer as compared to an entire chromosome missing or duplicated. But we know that, for example, chromosome 21 is implicated in Down syndrome. So most clinics would not transfer a mosaic embryo involving chromosome 21. 15 is a little bit different. 15 we know is associated with miscarriage risk, but there have been, some live births with mosaic embryos involving chromosome 15. Every clinic has their own policy on transferring mosaic embryos. So you would need to discuss that with your particular clinic. Most clinics, if they don't feel comfortable transferring an embryo, would offer you the opportunity to transfer that embryo to a different clinic that might have a different policy. Here in the Bay Area, I just wanted to, for the patients and audience members out there who are interested, there is a clinical trial ongoing at Stanford called the TAME trial. It's that acronym stands for the Transfer of Abnormal and Mosaic Embryos. And so they have patients enrolling currently in that study where you would meet with a genetic counselor, talk about the implications of your specific mosaic embryo. And if the clinic felt comfortable, they would actually proceed with that embryo transfer, and then they're tracking outcomes to hopefully provide us all a little bit more information about, when it's safe to transfer those embryos. But, so another last point I just wanted to make is that you're young, you're 34 years old with diminished ovarian reserve. And, I personally, if I were going to be your provider, would talk to you about doing another cycle in which maybe we don't utilize genetic testing. Actually, the data on genetic testing really shows that the subset of patients that really benefit from that are older women, so women over 37, 38 with a very good ovarian reserve. For women under 35, genetic testing hasn't necessarily been shown to improve live birth rates, particularly amongst women with diminished ovarian reserve. So I might even consider doing a cycle in the future where you transfer an untested embryo, and that might be something to talk to your doctor about.
Right. Or even before, because the trisomy 15, even if it's mosaic, can turn into a miscarriage at 5 or 6 months. And so that woman might even want to consider doing IUIs and waiting.
Hmm.
before putting herself through that. Thank you for that. Here's another question. Would drinking wine 1 to 2 glasses a week have any effect on my IUI? Would you advise no alcohol is better? What do you say?
This question comes up a lot, and what I generally tell patients is that abstinence from alcohol is safest for you, and but drinking in moderation potentially could be safe in the preconception period. But if you're in the middle of an IUI cycle, I would actually recommend abstaining from alcohol completely. We don't fully understand the risks, and that's because it's very hard to study. There are ethics behind doing clinical trials and with alcohol in pregnancy. So we don't really fully understand what the risks are, but being safer is always better. We know that alcohol does have an impact on both egg and sperm quality. And we know for men, potentially abstaining from alcohol for 3 months prior to a cycle is probably best, because we know that the process of spermatogenesis takes that long. Where the ACOG organization stands on that, and the American College of OBGYN, they actually state that, less than 4 drinks per week is probably safe. More than that potentially could be associated with lower IVF outcomes. But again, if you're trying to get pregnant, I would just limit it. It's really not worth taking the risk.
So I do wine and alcohol pairings. I don't know, this might be something you want to do with all the medications that patients take through their IVF. So with Menopur is what we call it. So they start with a French wine, and then when they add the Ganirelix, they add tequila shots. I'm just kidding. I'm totally with you on all of this. One day, I think of having like a wine bar in my office, or like a champagne bar where you can grab what you want as you wait. Okay. I am 45 years old, thinking of using an egg donor. What can I do to make my embryo stick?
So the good news about using an egg donor is for the age of the intended parent, whether you're 25 or 45 or 55 or postmenopausal, the outcomes are actually identical. And that's the first thing that I tell patients about using egg donors, is that it's really about the age of the egg, the age of the embryo, that matters in terms of live birth rates, generally speaking, of course. I think that what we do to assess the uterine cavity prior to an embryo transfer, which all fertility clinics will do, is at the very minimum we do a uterine cavity evaluation, which either consists of doing a saline ultrasound where we infuse fluid into the cavity. We look for overgrowth of the lining, polyps, fibroids, things like that, things that could impact implantation. And more recently, I've actually been doing more of these molecular tests on the uterine lining to actually look at this concept of window of implantation receptivity. One of the tests that's out there that has a fairly amount of pretty good data to support its use is the endometrial receptivity array, which is a test that is essentially taking a biopsy of the uterus and testing to see whether the tissue at that specific time that the biopsy was taken shows that the uterine lining is receptive. In other words, is it in a genetic state where it's going to stick to that embryo and improve implantation rates. And what we have found is that particularly for women with a history of implantation failure, up to 35% of those women can have a shift in their window of implantation, which can impact their future cycles. And so what you can do as a potential easy fix in their subsequent cycle is just slightly modify the duration of progesterone exposure that they get prior to an embryo transfer. There's another test out there called the Receptiva test, which is looking at the correlation with endometriosis, and there's some pretty interesting findings there too. So there's a lot of uterine tests that you can do, and those are just some of them that I've mentioned to help improve your outcome with the donor egg embryo.
So now we'll talk a little bit about sex. How often should I have sex around ovulation? When should I start having sex? Should I start having sex when I see my cervical mucus and my OPK is positive, or should I start having sex when the app says to have sex? What do you tell your patients?
So in general, if you're using an ovulation predictor kit, that's really an ideal way to time intercourse. So for in a natural cycle, let's just say it's a 28-day cycle. Typically the ovulation predictor kit will turn positive around cycle day 12 to 14, and your peak fertility window is actually the 3 to 6 days leading up to that window. And so having timed intercourse every 1 to 2 days during that peak fertility window is going to optimize your chances for success in that cycle. Having intercourse before that time period or after that really doesn't increase your chances. So really, if you can time it to those 3 to 6 days prior to ovulation, you're going to have the best chance.
Mm-hmm. Okay. So we finished all the email questions. Do you still have more time? Do you have a little more time for us, Meera? Okay,
Yes.
great. So now I'm going to go to the questions that you guys are asking live right now. And the first one I'm going to go to is someone who also emailed me, and she chatted it here too. So I'm going to read it right now. I'm new to fertility, and I'm noticing that I'm only being seen by nurses. I spoke to a doctor only for consultation, but my nurse did my first IUI too. Is that normal and common for clinics?
So a lot of clinics do utilize mid-level providers. Those are physician assistants and nurse practitioners who do have a skill set in performing IUI procedures. So I would say in our practice, for example, we have a nurse practitioner, and her scope, her skill set in terms of performing IUIs is equivalent to the physician level. It's a fairly straightforward procedure. Now, if you don't feel comfortable with that, seeing a nurse practitioner, I would focalize that to your practice and say that you would like some more contact with your physician and more continuity of care with them. We do, to the best of our ability, try to accommodate provider preferences in our practice as much as we can. But in general, mid-level providers are perfectly capable of performing procedures like IUIs, saline infusion ultrasounds, and in our practice, I have full trust that our nurse practitioner can do that just as well as I can.
Yeah, I have a PA here. She's awesome. I have patients that ask for her. They actually request her and
Yeah,
help me,
so
and
do
I'll
we.
take it. I do not take it personally. Okay, here's another question. How safe is it to have a baby in your 40s with IVF? They say the uterus doesn't age, but the rest of our body does. Should I be worried about having a couple kids in my 40s?
So yes, what I explained before about getting pregnant and all of that at different ages is true. You can get pregnant in your 40s and even postmenopausal. You can get pregnant if you prime the uterus with the right hormones, but there are actual increased risks that I definitely counsel patients about in their 40s. So, the uterus and the whole body is aging. In particular, the vascular, trees are changing, and there's more calcification. There's higher risk of cardiovascular disease, diabetes, metabolic condition for women in their 40s. So that then translates in pregnancy to higher risks of things like hypertensive disorders, gestational hypertension, preeclampsia. The risk of cesarean deliveries is higher in women in their 40s. And generally speaking, we do recommend additional genetic testing in pregnancy as well. So overall, while the chance of having a healthy pregnancy, assuming that your pre-pregnancy health has been optimized, your body mass index, your lipid profile markers, if those things have been optimized, the chances are that you're going to have a healthy pregnancy. But it is really important to take those few months prior to getting pregnant to get as fit and healthy as possible, because that's really going to determine your risk profile when you actually get pregnant. But there are, even if you've optimized for all of those things, there are still increased risks for women in their 40s.
Right. And if you're trying to get pregnant and you're doing fertility treatment, that's not the time to stop exercising. I feel like there's a lot of messaging out there that people should stop exercising. And I see patients, I gained 15 pounds because I was told to stop exercising because I'm going to start IVF. And I'm like, huh? Okay. Here's another question. Do you suggest antibiotics before egg retrieval and transfers?
So in our practice, we do use antibiotics, and I would say that differs based on which clinic that you go to. Generally speaking, with just a single entry with a needle into 1 or 2 layers into the ovary from the vaginal sidewall with proper preparation beforehand, the risk of infection is extremely low. It's much, much, much less than 1%. We do it because it's a very short course of antibiotics. It's, essentially, it's a safe antibiotic. It's just for a couple of days. So we tend to just sort of play it on the safe side, but I do know clinics that don't use antibiotics, and they probably have similar rates of infection in their practice than we do.
Right. I imagine yours is like mine, 0%.
Zero.
So do you recommend natural IVF without ICSI in patients who are doing PGTA as well?
This is a great question. And so just to sort of talk about that a little bit more, when you're doing genetic testing of an embryo, you're essentially biopsying the embryo at the blastocyst stage. And to get the most accurate result, you want to make sure that you're sampling only cells from the trophectoderm, or the cells in the outer layer of the embryo that are destined to become the placenta cell line. Now, if you do conventional insemination, which is the natural method, then you potentially could get contamination from sperm, and that might potentially affect the results of the genetic testing. Now, having spoken to several embryologists, both at my prior practices and my current one, I will say that a lot of embryologists feel very comfortable with doing natural insemination because they feel like they can perform the biopsy without risking contamination. And again, that might potentially benefit the outcome of the cycle. We talked about before how conventional insemination can improve fertilization rates, which then subsequently can improve the number of blastocysts you have to test. So while I will say most clinics do prefer ICSI to sort of minimize that risk of contamination, our clinic actually does do PGT cases with conventional insemination because our embryologists feel confident about that.
Yeah, and every lab's different, so you have to talk to your lab for sure. And I do like the term sperm contamination. There's something about it that sounds fun to me. Okay, what minimal protocol for DOR patients do you suggest?
Yes. So first of all, there was a really nice ASRM, or American Society of Reproductive Medicine, practice bulletin on this. So what I'm about to say is very much evidence-based as well, and has been shown to really be true in many different patient populations with diminished ovarian reserve. So in our clinic, we utilize both oral ovulation induction methods, medications such as Clomid and Letrozole, in combination with gonadotropins. So we might start a protocol after the onset of one's menstrual period with a few days of Clomid and Letrozole, followed by low-dose gonadotropins. Typically, the dose can range from 150 international units to about 225. And what's nice about those protocols, and sort of the rationale for that, is that when you do Clomid and Letrozole, you're increasing the amount of natural FSH for that woman. And we know that there's a lot of different isomers and forms of FSH that some eggs respond better to. And for some women, they might actually respond better to their own FSH as compared to the FSH that's has been grown in a cell culture with Chinese hamster ovary cells, So there's differences in response that we see. And, the idea is that you can increase your own natural FSH and then augment that with FSH to keep the momentum going. And overall, what you do find is that you have better egg quality, potentially more embryos, and better embryo quality at the end of that cycle as compared to these overly aggressive protocols that use high doses of gonadotropins.
And spending less money on medications.
Much less.
Okay.
Much less.
I'm 44 years old. My AMH is 0.13. Is it worth doing IVF? Right now I'm doing IUI.
Okay. Well, I think you have to be really realistic about what your chances are. I think that for women over 42 and in general, even with good ovarian reserve with an AMH over 1 or 2, even for those women, you're looking at success rates with IVF in the low single digits, less than 5%. And IUI is going to be even lower than that. So I think that, you have to really think about what those success rates are, and how much it's important for you to try to have your own biological children. And that's a really difficult conversation that I often encounter with my patients is, for some women, they want to at least try a couple of times before they move on to the donor egg option. But I do also provide and present very realistic numbers about what your success rates are going to be with both IUI and IVF, and for anyone, regardless of their AMH, but certainly it's even more challenging with a low AMH, to have good results, that the chances of success are probably a very, very low single digit number.
I agree.
And it's a lot of resources and emotional resources to invest in that.
So if your AMH is 0.1, that means you might get 1 egg. So a lot of times you won't, especially if you're 44. And so I would tell patients, let's do it for you to have closure so you feel like you did it. But you don't need to necessarily get to a retrieval to feel like you did IVF. You can at least ask this question and maybe start meds and see, and then be like, oh yeah, it just doesn't make sense for me to do it for 1 egg. But some people need to go there. They do.
Some people need to go there.
Yeah, men get these chances all the time in their 40s. Women should be able to as well.
Totally
what are
agree.
your food, drink, and activity recommendations during the 2-week wait?
Ooh, during the 2-week wait. So this is probably one of the most agonizing times for couples to be waiting for their pregnancy test and be overanalyzing every little symptom that they have. I totally recognize it, and I tell patients to to, find things to pass the time, watch a good Netflix, series to pass the time, because it really is a long wait. But in terms of my recommendations for, things to do, the first thing is that just know that pretty much everything's out of your control at that point. It's all about the embryo and the uterus and doing their thing at that point. So, if you bump into something, or if you have an extra stressful day at work, or, you eat something and you have a stomach ache, none of those things are going to affect the outcome of your cycle. So I reassure women on that front. I do tell women to, that intercourse is safe. I tell women that they can continue to exercise and stay active. And in terms of diet, I just tell women, obviously, to the common sense things like avoiding alcohol intake, and, smoking or exposure to secondhand smoke, to avoid those things. But in terms of a specific diet, I don't have one. I think that, eating healthy and well-balanced meals is generally the way to go. There is one thing that I'm a fan of, which is the pineapple core. I don't know if you're a pineapple core fan, but
you see all the pineapples behind me? Pineapple, pineapple.
So for those of you out there that don't know about the pineapple core, there is a component called bromelain, which have been potentially shown to improve implantation rates. So if you like pineapple, go out and buy one, eat the whole thing, including the core. If you don't want to do that, you can buy supplements that are essentially bromelain in a pill, and you can take that. But, don't stress about that. We don't really know if that helps or not, but pineapples are fun and they taste good. So why not if you enjoy them?
That's true. Okay, here's another question. It's an interesting one. I have one normal embryo with my own eggs, but I want 2 kids. So I already know I'll need donor eggs. Should I create my donor egg embryos and transfer that one first to see whether I can get pregnant before I transfer the embryo with my own eggs?
Can you say that again? She has one embryo using her own eggs?
She has one embryo with her own eggs, just one. And she already
Okay.
knows that she will need donor eggs just with everything that she's been through. Should she use the donor egg embryos first or use her own eggs first to see whether she can get pregnant or not?
I would say use the embryo that you have now. I mean, go through if you have one embryo, what I would make sure is that you have done every single test possible to optimize for success on that transfer. So in my practice, what I do is I offer patients not only the saline infusion ultrasound, which I do for all patients to ensure that from a structural standpoint, the uterus is perfect, but I also offer women the endometrial receptivity array test to ensure that the timing of an embryo transfer is going to be optimized. There's other tests you can offer as well. But I would say that, if you have an embryo, you should go for it, especially if it's been genetically tested is a good morphology embryo. You have a very good chance of a live birth, 65 to 70%. So I would go for that.
Okay. Here's another question. I have a 4-cell day 3 embryo. What are my chances that it will turn into a healthy pregnancy?
So at the day 3 stage of development, typically embryos are at least 6 to 8 cells. So the fact that your embryo is 4 cells means that it's a bit slower developing, and that does correlate with lower implantation rates. Now in our clinic, we do a fair amount of day 3 transfers, and I can tell you that we've had a good number of pregnancies from these slow developing embryos. So you certainly have a chance. It might be a little bit lower. Your age plays an important role in sort of predicting your success. So if you're a younger patient, then your success rates might be higher. I can't quote you a number because I don't have that information, but I can tell you anecdotally that I've had a lot of pregnancies from these quote unquote slower developing embryos at the day 3 stage.
Right, great. So someone's asking, I'll answer this question. Can we do an ERA in the same cycle as our first transfer? And the answer is no. An ERA is separate. So step 1, do your IVF. Step 2, do your ERA. Step 3, then do your FET. Here's another question about plasma cells in the biopsy.
Can I say one thing about that, Amy?
Yes, go for it.
There's actually a new test that's coming out soon from iGenomics that developed the ERA platform, and it's a non-invasive, or it's essentially extracting fluid from the uterine lining to get the same information that you do from an ERA biopsy. So hopefully in the next year or 2, we might actually see the ability to perform a sort of less invasive biopsy test and get that information potentially the day before transfer, find out if the lining is receptive, and transfer the embryo the next day. So
my
that's in the pipeline.
My patients really enjoy the biopsy, though. What are you talking about? Okay. Far from. Okay. That's really great information. What shall you do if plasma cells are in the biopsy of the uterus?
Mhm. So plasma cells are a sign of potentially a condition called chronic endometritis.
Mm-hmm.
This is a condition that, you wouldn't even consider treating if a woman was not trying to get pregnant. But in the setting of trying to conceive, there have been some studies that show that it can increase the risk of a miscarriage. It's sort of a chicken or egg, not knowing where those plasma cells came from, if they were a result of a prior miscarriage or if they were there before and potentially caused it. But nevertheless, I do recommend a 2-week course of doxycycline, which is an antibiotic, to clear the infection. Some clinics will repeat the biopsy
Mm-hmm.
after the course of antibiotics to ensure that those plasma cells have cleared. The efficacy of those antibiotics is quite high, so I don't actually perform the repeat biopsy, but it is worth doing, especially for couples who have a history of recurrent pregnancy loss. It is part of my workup.
Yeah, exactly. Perfect. So I'm 31 years old, cycle day 22, trigger shot. I had a 16 millimeter follicle and my IUI was on day 25. Are my chances lower because of that? Because of the fact that I was triggered so late in my cycle?
The trigger happened though 2 days prior to the IUI.
Right, right. But
Yeah. Okay. Okay.
it was cycle day
Okay.
22.
Yes. So in general, the time that it takes for a follicle to mature and develop can be highly variable. It can take 4 days, or it can take 20 days, or it can take longer than that even. But as long as your provider is looking at your follicle development and tracking its trajectory over time, checking estrogen levels, checking other levels, and looking at the uterine lining, it actually doesn't affect the outcome of your IUI success. It's not dependent on the number of days it took for that follicle to develop.
Great. So
Hmm.
we're going to answer 4 more questions. Okay.
Okay.
These questions are all so great. So thank you everyone for asking them. So here's a question. I miscarried twins and I'm so sorry that you did that at almost 9 weeks. We still have 4 embryos which have not been tested. Should we go ahead and test them at this point? What would you do?
I'm so sorry that you lost that pregnancy. The first question I would ask is if you did genetic testing on the products of conception, if you had done a DNC or had collected that tissue, and if there was a genetic etiology to the pregnancy loss, then I would say that it might be worthwhile doing genetic testing on your remaining embryos. It is very traumatic to go through a pregnancy loss, and at that point, you want to take every measure to reduce your risk of miscarriage in your next cycle. So if you don't have that information, and a lot of OBGYNs don't do products of conception testing. So in many cases, when we see patients, we don't know. We certainly believe that genetics are the most common cause of miscarriage, but we also know that it might be slightly higher in twin pregnancy gestations as well. So again, it would depend on your age, the quality of those embryos, and a lot of different factors. If you had several embryos, they were good quality, I think it's potentially worthwhile considering testing, but really getting good counseling from your doctor about what the limitations of those testing results are. You potentially could get false positives, false negatives. There's still going to be a risk of miscarriage even after you go through genetic testing that could be as high as 10 to 15%, but it likely would be lower than if you had untested embryos. So again, kind of going through those trade-offs and pros and cons of testing versus not in your specific situation would be important,
Great.
but it's
Thank you for
potentially
that.
worthwhile.
Thanks. Caffeine, is it okay? I heard that even 4 ounces was bad, so I stopped drinking coffee. What do you tell your patients?
So in general, a lot of people need coffee to function. I'm not one of them, thankfully, but a lot of people do need them. So a cup of coffee a day
I'm one of them.
is
I'm double fisted over here. I'm definitely one of them.
is fine. A cup of coffee a day is fine. More than that, you probably want to try to limit it. But in general, caffeine is a diuretic. So if you're going through a stimulation cycle, I just tell women that you want to take extra precaution to hydrate more, but you can continue to drink your cup of coffee a day.
Great. And last 3 questions. How do you feel about DHEA for women with decreased ovarian reserve? AMH is 1.3. I mean, I honestly don't think of the AMH of 1.3 as necessarily DOR. I usually recommend DHEA for AMHs that are less than 0.6, but how do you feel about it?
I agree. And in general, I would say that my spiel on supplements is that I'm not a huge proponent of them. I say generally, if you can't hold all of your medications in one or two hands, you're taking too much. So, all of these supplements, and there was actually a really nice Cochrane review, which is essentially a study that synthesized a lot of the papers on supplements. Essentially, what it showed is that there really wasn't any single supplement that was the magical miracle supplement that could improve your egg quality. So much of it is just your natural biology. But I did mention before that coenzyme Q10 potentially can improve egg quality. DHEA, I agree with you about kind of the lower AMH levels. It might have a benefit, but with your AMH level, I would say, it does have side effects and it's costly and all of those things. I don't think that there's a huge benefit for you in particular. I would say that, healthy lifestyle, having a healthy body mass index, eating well, those things are far more important for determining your egg quality. And there aren't too many external things that can affect that.
I came up with an easy mnemonic for people. Your egg quality is based on your age. No, it gets better. Just wait. The A is age, the G is genetics, and the E is environment. Right? And you can't control your age or your genetics, and your environment you kind of can't control depending on where you live and what you were surrounded by growing up. And then the only other thing we can do is maybe take supplements. And I don't know why some people react better than others. That might be in their genes too. Okay. So I missed what you mentioned about slow developing embryo transfer success. Can you repeat that? So the person who brought up that they had a 4-cell day 3 embryo, and you've had success with day 3 embryos that are slower growing. Can you just kind of talk through that one more time?
So again, at the day 3 stage of development, we typically like to see the embryo reach at least 6 to 8 cells. We also look at things like symmetry of the cells, the fragmentation of the embryo. So the number of cells in isolation is not enough information. But I will say that in our practice, if we had a 4-cell embryo on day 3 and we were preparing you for an embryo transfer cycle, the way that we would time your transfer would actually be that we would time that transfer as if that embryo were a day 2 embryo, because on day 2, the embryo is 4 cells. So we would adjust for that as we would prepare your body for the transfer. And that's how we go about doing that. And as I said before, we've had many successes in taking that approach. But overall, your question about success rates, it would depend on your age. I would say if you're a younger patient under 35, that you have a higher chance of implantation as compared to, if you have a 4-cell embryo on day 3 in your 40s, that embryo probably has a less than 5% chance of implantation and live birth rate. So, and again, those are factors that predict blastocyst formation, both in vivo and in vitro. And so for a 4-cell embryo on day 3, there's probably a pretty low chance that embryo is going to make it to the blastocyst stage, either in a lab or in the uterus. But it probably has a better chance in vivo in your body as compared to the lab. So that's why in cases where we have seen slow embryo development in prior cycles and in, at other clinics and in our clinics, sometimes we will make the decision to not transfer blastocysts and transfer embryos at an earlier stage. And if we see that slow development, we will, essentially adjust for that in terms of timing when we do your FET.
Perfect. Okay, last question. Meera, thank you for all your time. We've been talking for almost an hour.
I know, it's been great.
And
These are great questions.
We can keep
I
going.
hope people are finding it helpful. Yes, please keep going.
Last question. I did the ERA test, but genomics said the sample was too small. Has that ever happened to you before?
It has, and I'm so sorry that happened to you, because that does mean you have to go through another biopsy. The company is very specific about how much tissue it needs. So if you give either too little or too much, they give you a invalidated result, piece of paper. So unfortunately, I have seen that. And it might be related to if you had the test done because you had a thin lining and you may not have enough tissue to get. But I would say I actually don't think I've ever had a patient who, upon repeat biopsy, had the same result come back on the second chance. So hopefully you can do the process again, get a good sample, get the results, and move on to success on your next cycle.
Awesome. Well, everyone is sending us so much love. Thank you guys for watching today. Meera, can you just tell everyone where you practice and where they can find you for people who want to reach out?
Sure.
Yeah.
Yeah, thank you all for listening. I hope you guys benefited from this Q&A. And if you have any follow-up questions, you can definitely message me. I have a Instagram account that is very active, and my handle is at Dr. _Meera Shah, MEERASHAH. And I practice again very close to Dr. Amy in the San Francisco Bay Area at Nova IVF in Mountain View, California.
Awesome. Well, thank you. Have a wonderful rest of your day. And thank you everyone for watching, and hope you'll join us back here soon. And Meera, we'd love to have you back for another Q&A in the near future. Okay.
I'd love that too.
Okay.
Thank you so much,
Awesome. Thank
Amy.
you. Have a good one.
Bye,
Bye-bye.
everybody.
Bye, everyone.